To that with I'm really excited to be here. Pharmacogenomics is one of my passions, and especially in mental health. I'm excited to talk to you all about such a pointed focus in pharmacogenomics, and hopefully this will give you a background 101, an overview of pharmacogenomics in general, and then we'll really dial it down to how you can implement this and work with it in your clinical practice setting. So my exciting news, which I'll keep completely separate from this presentation because this is a CE presentation, but like Summer said, I own my own pharmacogenomic consulting company, and the exciting news is that we're planning on bringing a laboratory here to the state within the next couple months. So hopefully we'll be able to provide, be able to bill on insurance and make it a more comprehensive and local service. And it's something that I think you'll see in the next 30 minutes that I think we really need here. So I have a very laid back presentation style. I've got the chat up, so I'll do my best to monitor the chat while I'm going through my slides. But again, I'm really laid back. If there's something that's confusing, if you want to unmute yourself at any point and jump in time, I absolutely will not mind if anyone jumps in and interrupts me, because we'll just move through this together. So today's roadmap, we'll start with some background and statistics of PGx or pharmacogenomics. And then I'll spend some time going over nomenclature and biology. And then where I really want to spend the bulk of the time is pharmacogenomics guidelines, where you can look up additional information, and some literature specifically pertaining to mental health. We will talk about ordering a pharmacogenomics test, overlaps in other clinical areas outside of mental health. And then lastly and briefly, I will touch on something called phenoconversion, which is what we call the Achilles heel of pharmacogenomics. So background and statistics. How does pharmacogenomics really fit into the landscape of clinical practice? So we've likely all heard about pharmacokinetics, how the body affects medication, and really this is pertaining to metabolism if we back away and look at it from a bird's eye view. Pharmacodynamics, how the medication affects the body, and this really has to do with receptors and transporters and things on a very small granular biological level. And then pharmacogenomics, how these two interact in a specific patient to customize medication management and how genetics impacts medication. So again, we've really honed in on, especially as a pharmacist, PK and PD, but really talk about PGx and incorporating this into our clinical skill set. This is a great visualization of pharmacogenomics. And we've always approached medicine looking at the left with this blockbuster one-size-fits-all approach to drug development and prescribing. What pharmacogenomics is trying to capture is the personalized prescribing aspect of medication management. So when we take genetics into account, some people will respond great to a normal dose. Some people's pathways will require a lower dose, others a higher dose, and then some people actually might respond to a different medication altogether and need to go through a completely different medication pathway. So the goal of pharmacogenomics, and something that really is said in this sphere of medicine all the time, is we will hopefully find the right drug at the right dose the first time. So how does PGx work? This is just from a very high level view workflow perspective. A pharmacogenomics test is normally taken as a buccal or a blood sample directly from a patient. So you do not have to take a blood test. The way that we do it within my company is we use buccal swabs sent directly to the patient. But this sample is then genotyped for genes and alleles. And we'll talk about the nomenclature in just a second. Once the sample is genotyped and the report is made, the genotype, the phenotype, and the alleles will be spit out. And ideally, we would love for those to be built into some kind of clinical decision support tool. So there are clinical decision support tools on the market right now. It would be great if your report or your lab had an interface that already worked within your organization so that you could just plot this data into the workflow and use it almost as another lab value. But the ideal workflow, again, integrating these records and these results into the EMR that will work both with your computer and with the clinical decision support tools that you've put into place. So let's talk about the cost burden of non-optimized medications. And a non-optimized medication, this can come in various shapes and sizes. I mean, this can be a wrong dose, the wrong drug for an indication, a drug-drug interaction. But what I want you to take away from this slide is that the US spends more money on non-optimized medications than it does the top 4 disease states combined. So cardiovascular disease, diabetes, cancer, and arthritis, We spend more on fixing what has been non-optimized for medication management than we do any of those disease states. Another statistic that I don't think is widely shared is that we spend more on non-optimized medications than we do on drug research and development itself in the US. So again, just to put that into perspective of how important it is to take some of these things into account, hopefully genetics, in determining the correct medication prescribing. The importance of PGx is that 99% of individuals harbor a genetic variant that may impact medication response. I mean, 99% of anything for any statistic is almost unheard of, right? And I can tell you that with the genomic tests that I've done, I've never had a test where someone does not have an abnormal pathway in some way, shape, or form. Every 2 minutes in the US, a life is lost from a non-optimized medications. That is the equivalent of a Boeing 737 falling from the sky every 6 hours. I mean, it is just staggering how many times we lose a life in the US and how often it is that we're dealing with non-optimized medications that have really tragic ends. Again, adverse drug reactions are the fourth leading cause of death in the US, ahead of all those disease states that we talked about. And 50% of patients are on a prescription drug that is either ineffective or toxic for them. So let's dial this in even further. I want to hone in specifically on mental health here in Hawaii, specifically on why this is so important to you all. And, you know, I feel like I'm preaching to the choir here because you guys are probably way more intimately familiar with some of these implications than I even am, but it is no secret that we are having a mental health crisis in the state. This is something that I think is kind of scary to look down the barrel of, with the time it takes to get treatment, the time it takes to get in front of a physician if you're a patient, the time it takes to achieve a clinical outcome. So really any kind of improvement we can make on this process amidst a great provider shortage could really not only save time to treatment and save money, but also truly save lives if we're able to dial in on the correct therapy at a faster amount of time. This last quote at the bottom is directly from the Access to Care report published last year. But again, I'm preaching to the choir. Psychiatry and mental health counseling are far and away the two professional areas needed most, according to providers in the state of Hawaii. So I know Kelly will appreciate this because I took this image on the left directly from the Community First Access to Care report, but nearly 6 in 10 patients they've experienced healthcare delays in the past year. And looking on this right side, really, again, dialing this into mental health, I want to articulate the percentage of patient populations for which a particular drug is ineffective on average. And at the top there, you can see that antidepressants, almost 40% of antidepressants are ineffective on average. So we'll talk about what kind of antidepressants we can look at with the pharmacogenomics panel. And again, just this entire clinical picture I want to paint of how many people are waiting for treatment, how long specifically with mental health it takes to get to a stable mental state. When we look at some of our first line agents, we're looking at weeks or months at a time. And really for patients that are in a state of mental health crisis, the time can really save lives if we're able to streamline that. So the standard of care in many aspects of mental health prescribing, as you all know, is trial and error process. I mean, there's certainly clinical considerations we can take into account, but a lot of trial and error for mental health prescribing. And when we look at pharmacogenomics specifically, insurance companies often require the patient has multiple medication failures before they will cover a pharmacogenomic test. So we're hopefully going to have some conversations here in the state to change that. Right now, there are a couple insurance companies that will cover pharmacogenomic panels, but unfortunately, it's normally not in a proactive manner. It's after you've already failed a certain medication or it's already been a certain amount of time before they'll cover the test. And this trial and error approach can negatively affect multiple aspects of patient care. So one, patient compliance, if they have treatment-resistant depression after trying a certain amount of medications, all these adverse drug reactions. But overall, I've found anecdotally, I don't have science to prove this, but when you're dealing with pharmacogenomic testing and patients that feel like they're getting genomic driven or personalized medication, it really does improve the patient provider relationship, knowing that you're prescribing something that works for them, knowing that they're getting treatment that's specific to them and their clinical picture. I've just found anecdotally, it really does improve the patient provider relationship as opposed to trying and failing a couple medications. So I will get into the nitty gritty here with pharmacogenomics. And Beth, I see your question, the cost of the test. So the answer is it varies. My company can offer a broad panel test that covers 30 to 60 genes for $250. I know that a lot of insurance companies are outsourcing to ARUP, or ARUP, I think is the name of the company. I don't know if you pronounce it by letter or by saying ARUP. ARUP will charge anywhere from $200 to $300 for a single gene test. But again, it's all working within the network of what the insurance will cover. I know there's broad tests out there for less than $300, to answer your question in a simple way. So nomenclature and biology. The most important drug metabolizing enzymes are the cytochrome P450 enzymes, or the CYPs for short. Typically, these are abbreviated again by CYPs, like 2C19 is very familiar, 2D6, but this is how it's broken down. So you've got the cytochrome, you've got the gene family that is immediately following that cytochrome with a single number. The capital letter indicates the subfamily, and then the numeral for the individual gene. So taking that even further, and what we look at in pharmacogenomics, so you can see we retain all that information at the bottom, the cytochrome, the family, the subfamily, and the gene. But now we're looking at this haplotype, and this haplotype is what's considered a star allele. So our normal function enzyme activity, or the wild type, is normally denoted by star 1. But any altered function variants, and those are different per gene, are star 2, star 3, star 4, all the way up to a large amount of star alleles, depending on the gene itself. Single genes like 2C19 have many star alleles, and results are reported as diplotypes, which is 2 of these haplotypes.
So there's a question about what is a gene family?
Gene family helps to determine, before we even break down to the subfamily. So gene family is just a way to determine another subset of the pathway. So like 2D6, all of the 2s would fall into the same family. 2C19, they would still fall within that gene family, but it's not as specific as the subfamily. I don't know if that's a great answer, but it's just a way to dictate between the different types of family based off of the origin of the family itself.
Would a gene family be like that gene in different people and then how it's expressed?
No, that would be the haplotype.
Ah.
So the gene family is consistent from person to person, but it's really the haplotype and these enzyme activities of the individual genes that's person specific. Does that help, James?
So we all have genes, and we all have genes that do similar things, but they all work in different ways. And so you can see if they're going to break down drugs faster, slower, or not at all, right?
Yes. And we will focus on that on the next slide, Kelly. You are right on par with where my brain is going. But what pharmacogenomics really focuses on is looking at these different star alleles and these different haplotypes and diplotypes, which translate to different speeds of metabolism. So I think this will come into a better perspective with this slide here, is that based off of those haplotypes, so based off of which allele that you have, if you're 2D6 with the star 2 allele, or if you're 2C19 with the star 7 allele, or whatever that may be, all of that translates into one of these metabolic pathways. So, and it's different per family and it's different per gene. So I can't say that a star 2 allele in every single gene is going to have the same response. It's all family and gene dependent. But the way that it translates is, I like to think of this as a highway. So the most important pharmacogenomic variations, like we said, all of these are generally expressed in the liver. The CYP pathways in the liver is where pharmacogenomics really focuses. And historically, we've treated patients as if they're all normal metabolizers. So here, right in the middle. And again, the way I like to think about this is as a highway. So each person will have a highway from mom and a highway from dad. And if it's working appropriately, both of these highways is going to work normally, and you'll have 2 active alleles, and so you'll have 2 active highways. And then, as with many other genetic traits, individuals, you normally inherit one from each parent, but in some patients, you have extra highways. So let's say you have a normal highway from mom, and then you have a fast highway from dad, or an extra highway from dad. So now those patients will present as ultra rapid metabolizers, and they would theoretically go through drug at a faster rate than someone with this normal highway, the 2-lane highway. And alternatively, if you are an intermediate metabolizer, so you have one active and one inactive allele. So one of your highways is working and one of your highways is not working. So you'll process medications at a different response or a slower response than you would for as a normal metabolizer. And the same for poor metabolizers. Some have 2 non-functioning alleles, one from each parent, and those patients are not metabolizing certain medications at all. So does that make any sense, the way that this is depicted, with having one highway from mom, one from dad? You can have anywhere from no functioning to extra highway pathways based on your alleles.
So everybody has this gene, but it looks different in everybody, or not everybody, but it looks different in many people, and it looks like one of these ways.
Sure. Yep. And we'll even break it down. I've got a slide towards the end of the presentation too that specifically looks at different highways in Asian patients, which is a population that we have to take into strong consideration here in our state. We have such a beautiful demographic background, but it's not consistent across race. It's not consistent across a lot of other variables. It's just dependent upon which highways and which alleles you're interacting with or you're inheriting from your parents. So another way to think, or another, I guess, complication with pharmacogenomics is that sometimes genetic variations will impact active and pro drugs differently. So as a pharmacist, this is something I think about all the time. Some medications we give are in active form, and that's great, and we directly metabolize them out of the body. Some medications we give in inactive form, and these drugs are called prodrugs. We have to then use metabolism, or we have to use these pathways to convert the medications into active form, and then they are eliminated from the body. So this plays into drug response when we think about an active versus a prodrug, and how these different highways or speed of pathways affects the concentration in the body. Drugs have a therapeutic range in which the medication works, so above that green line, but does not cause any toxicity, so below that red line. This window varies by drug. Some medications have very large therapeutic windows, some have very small or narrow therapeutic windows. But for active drugs, we normally expect both intermediate and normal metabolizers to be in the therapeutic range. So again, think of these medications at standard doses as traffic on a highway. There will be more traffic if there is only one lane to clear it, and far more traffic if there are no lanes to clear it. So James, let's see. I'm not sure I understand what the highways are. Do alleles at the same gene produce proteins that act at different metabolic pathways, or are they just more or less potent at a particular pathway? So alleles at the same genes act differently. There's different alleles per gene. So just because you are a star 2 allele for one gene does not mean that you're a star 2 allele in another gene. You can have different diplotypes and haplotypes depending on the gene. And the highway will be different for each gene. So a 2C19 star 2 would be totally different than a 2D6 star 1 star 2 or star 2 star 2. Like the responses of those highways are specific to the gene and the family itself. But you can apply the highway concept to, do you have a pathway or a highway that is active based off that allele and that haplotype, or do you have a pathway that is inactive? So it's not consistent across all genes. It's specific to that one pathway, but the highway concept can still stand of active versus inactive. So putting this into a bigger clinical picture with drug response. So let's look at poor metabolizers. They have low or absent enzyme activity. They are more likely to experience adverse effects because they have high levels of unmetabolized drugs. So again, this is an active drug. We are giving a drug that is already in its active form. It is already going to have a response on the body. If you have a poor metabolizer and two of those highway pathways don't work, you are going to accumulate high levels of that drug in the body. So that's why you see these poor metabolizers generally have toxic levels of the medication, or that's what we have to be on the lookout for. For intermediate and normal metabolizers, we generally see if they're within therapeutic window, but for ultra rapid metabolizers, so now again, we're giving this active drug, it's already in active form, and we have an ultra rapid metabolizer that is burning through this medication at a higher rate and eliminating it from the body. So we see it generally below therapeutic level, or we worry about it being below a therapeutic response. And this is completely flipped when we talk about a prodrug. So a prodrug, now we are giving it as a biologically inactive precursor that has to undergo metabolism before it has a clinical response on the body or a therapeutic response on the body. So ultra rapid metabolizers. Now we're giving this drug in an inactive form and we're ultra rapidly metabolizing it to the active form. So now we worry about ultra rapid metabolizers converting it to an active form at an excessively high rate. Normal and intermediate metabolizers, they're generally still within that therapeutic window, depending on the drug. But poor metabolizers, now we're worried again about the opposite. So we've given this drug, it's an inactive form, and they are less likely to convert it to the active form because they are a poor metabolizer of an inactive drug. So I'll flip back and forth just so you can see these two again. And I'm sorry if this is confusing. Let me know if I need to explain this again. But again, it depends on if you are giving an active drug that's metabolized out of the body by these pathways, or if you are giving a prodrug that we're responding or we're expecting this to be converted into its active form. Can we alter ultra-rapid immediate metabolizers and poor metabolizers, or we can only adjust the drugs? That's a great question. So you cannot alter the alleles and the diplotypes and the haplotypes. That's all specific to genetic information. You can only alter and adjust the drugs. So guideline and literature review. Where can you get more information on pharmacogenomics resources? Where do these guidelines come from? What do you need to know? CPGx is before I move past that, some examples of active drugs and prodrugs. Most drugs we give in active forms. The biggest prodrugs, if I had to list them off the top of my head, Plavix, clopidogrel is a prodrug, codeine is a prodrug. Codeine's metabolized into morphine, it's active metabolite. And tramadol is another prodrug that I see, but I know I've got a lot of physicians in the chat, so if you want to add some more, I'm totally open to you chipping on, but those are the three biggest that I can think of. Does the test check for metabolism and reaction only to a specific drug? So I'll talk about which medications the test looks at. Something important to consider is that this test does not look at every single drug on the market. There's thousands and thousands of drugs on the market. This test will only look at certain medications that fall under a certain amount of evidence and data, or that they have CPGx recommendations. So CPGx is the guiding body of pharmacogenomics, and some drugs do alter gene activity. So Dr. Renata, I don't know if it's related to pharmacogenetic gene activity. That would be a new fact for me if we're able to alter the drug metabolism based on star alleles and haplotypes and diplotypes. But I do agree, some drugs do alter gene activity. With those drugs, I'm normally thinking of oncology-specific medications where we're giving certain tumor targeting medications, or for some of the asthma medications where we're really honing in on interleukins. Those are different than using the pathways that already exist in your liver based off of a pharmacogenomic test. So because, again, that's a really great question, and thank you for asking. This is different than tumor testing or biological targeting of a certain medication or a certain gene. This is looking at the pathways that already exist in the body based on liver enzyme and the CYP pathways. So I haven't heard of drugs altering the CYP pathways, but I hope that differentiates between the two kinds of drugs, or at least what pharmacogenomics can measure. So PGx information. CPIC is the guiding body of pharmacogenomics. It is endorsed by multiple medical societies. It is indexed as guidelines in PubMeds. But the Clinical Pharmacogenetics Implementation Consortium, it is a great resource. I would ask everyone to pull it up at some point. If you're interested in pharmacogenomics, you can search by guideline, you can search by drug, you can search by gene. It is a very user-friendly website in general, full of information and which guidelines are clinically actionable. And you can even look at their specific diplotype, haplotype, or phenotype and plug that into which medication you're looking at, and it'll give you recommendations to dose adjust around it. PharmGKB is another great resource. This is a larger data aggregate. This is kind of the hub for a lot of data, especially for data that hasn't been peer reviewed in CPIC just yet. PharmGKB is this huge aggregate resource. And then the FDA, a lot of people don't know this, has actually been publishing information on pharmacogenomic and pharmacogenomic associations for a couple of years. They've broken it down into 3 different classes with sufficient evidence for therapeutic management, potential impact on safety, so they'll look at PK and PD, and then again, the impact on the pharmacokinetic properties. So the FDA actually, in some of these well-established drugs that have pharmacogenomic implications and considerations, they've already started including PGx data into package inserts and drug information. So just another place and another resource to look at. I will say the FDA has great broad data. CPIC is really where you want your guidelines for dose adjustments and specific clinical considerations. The FDA doesn't normally get that granular. So the clinical context of CPIC, when you pull up CPIC, you will see that there are 4 levels of data within the guidelines themselves. So similar to other guidelines, level A data is much stronger data, all the way down to level D data, kind of like being anywhere from strong randomized clinical trial evidence all the way to, different case reviews and whatnot. But what I put a star by is CPIC level A and CPIC level B. So these are medications based off of genetic information where there's at least one moderate or strong action that should cause a change in prescribing, or at least an optional action that should cause a change in prescribing. So these level A and level B are your clinically actionable CPIC guidelines. And that is what you want to consider when you're looking at the strength of evidence within the website itself. So I'm going to work my way into, we're already at 12:32. I'm going to work my way through 4 different literature cases, but any questions on the background before I move forward? Any additional data I need to go back and provide clarification on? Okay. And aloha from Maui. I see that message. Love that you're here. All right, so let's dial it in. PGx in depression and anxiety. So this looked at a couple hundred patients that were receiving pharmacogenomic guided therapy from providers versus just regular standard of care treatment as usual for treatment of major depression. Remission rates after 12 weeks were more than doubled with genomic guided treatment versus not genomic guided treatment. And something else to consider, especially with this study, and this was published in the Journal of, what is this, Psychiatric Resolution in 2018. But my favorite part about this study is that the number needed to treat when we look at genomic guided therapy versus treatment as usual was 3. So this is interesting because especially number needed to treat for antidepressants in general are normally much higher than 3. So this is just a great study that highlighted the use of PGx in patients that are severely depressed. PGx in major depression, again, another guided trial. This one is slightly larger, looked at just over 1,000 patients. It was a blinded placebo-controlled study in outpatients with treatment-resistant depression. No difference in symptom improvement on the PharmD scale. However, there were differences in response rates and remission rates that were in favor of PGx guided treatment. So again, looking at pharmacogenomic guided treatment-resistant depression versus treatment as usual or TAU, and statistically significant response rates and remission rates, even though there were no differences on the PharmD scale. Something else that was important is that patients who switched off medications with significant gene-drug interactions showed greater improvements and fewer adverse effects than those that remained on them. So we also will look at what's called phenoconversion, where we take drug-drug gene interactions into account. But this is something that's brought into light with pharmacogenomic testing, is also these drug gene interactions, pulling off clinically inappropriate medications and streamlining therapy when we can. This is something that is near and dear to my biased little heart as a pharmacist, but looking at pharmacogenomics and depression and involving the community pharmacist. So again, really interesting angle. Patients with depression or anxiety presented to a community pharmacy, and they were either given a pharmacogenomic test or a blank cheek swab test. So the patients were blinded themselves. But patients in the pharmacogenomics group showed a statistically significant greater improvement on PHQ-9 and GAD-7 scores than those with treatment as usual over 6 months. And what's even more interesting to me is that prescribers were more likely to accept recommendations from a pharmacist when they knew a pharmacogenomics test was used. So prescribers were primarily PCPs. Something that we have to point out is that there was obviously the payer mix influenced the recommendation acceptance from the pharmacist, but just another angle of how we can get pharmacists involved and really leverage team-based care, even if it's not specifically within a clinical setting, but involving our community pharmacy colleagues. So this is the most recent trial. It just came out last year from the Department of Veterans Affairs. And a lot of people are taking this as a negative PGX study, and I'll explain why, but I do think that there's some great pearls that can be taken out of the study. After 6 months, this was a randomized controlled trial or randomized trial comparing pharmacogenomics guided therapy versus, again, treatment as usual over the course of 6 months. And the outcomes were the number of drug gene interactions or remission based off of PXQ-9. So the PGX provided care did help avoid negative gene drug interactions, and reduction in response favored PGX. But they were affected by race, PTSD. When we're dealing with depression, there's a lot of other factors that are taken into consideration with the complex presentation of these patients. There was no assessment and treatment of adverse effects. The PGX arm achieved greater rate of remission over the course of 6 months, but it did not significantly differ after that 6-month period. So a lot of people will say this is a negative PGX trial because there was no difference after 6 weeks. But what I take here is that the pharmacogenomics arm did reach that original drug at a faster rate. It just didn't have any clinical differences in outcome after 6 months. But again, if we're talking about getting to the right drug at a faster rate in an overburdened healthcare system, getting to that right drug is important to consider the time reduction in there too. Are pharmacists ordering genomics tests before RXs are dispensed to patients? No, not in this state. Nope. So current pharmacogenomics applications in psychiatry, and I've got 2 slides of this, so I'll just stay on each one for a little bit. So I don't want to read out each one of these medications. I trust that you all can read, but this is just the medications that are related to psychiatry and mental health. So we've got almost 30 medications with mental health. Most of these are CPIC level guidelines A and B, but here's a list of them. You'll see most of our SSRIs and SNRIs are on this list, along with tricyclic antidepressants are another pretty common class. But here is the second half of that panel, and which medications are included and which genes are dominant. Biggest genes in mental health by far, 2D6 and 2C19, if I had to put my finger on which ones affect the mental health medications. So considerations for testing. Timing. This is something that, because we don't have a local lab here now, I like to think of when people get pharmacogenomics tested, you're put into 2 buckets. So you're either reactive, you're just in time, you're already at the point of care, you're already needing a new prescription and we pull a pharmacogenomics test, or there are patients that are interested in getting proactive testing. Ideally, what should be done is a proactive test so that by the time they walk into an office, or by the time they need something, or by the time the clinical picture changes, they already have their genetic information in hand, and we have a much better place to start with therapy regimens, proactive versus reactive buckets. Another thing to consider is that we don't have a local lab, a local pharmacogenomics lab at the moment on island. So the turnaround time with the fastest lab that I can find is just within 7 to 10 days. At one point, I was waiting almost 2 months for these tests to turn around. But again, proactive versus reactive and the utility of having those results on hand. There's a couple different scopes, and this is where I can just blanketly say without any bias, the way that insurance will normally cover these tests is they will try to prevent from doing a broad panel. So they'll want to look at just 2D6 and 2C19 for a mental health medication. They won't want to pull a multi-gene broad panel. They'll want to do just a targeted panel based off the medications that are needed. There's also a huge breadth of evidence in the decision-making process. So that's something to consider is which lab you're going to use, which clinical decision support tool they use, what other information is being pulled in with this panel. Can cord blood after newborn delivery be used for genomic testing? You know what? I am so familiar with just using the buccal swabs. I don't know the answer to that question, but Renata, if you want to put your email in there, I can pull that off or pull that up and get back to you. My assumption would be yes, but I don't want to say that with 100% confidence. And then another thing to take within testing consideration is reporting. So some of these clinical decision support tools, and this is different on 23andMe, this is different based off whatever lab you go to. Some of these clinical decision support tools will have red light, green light, yellow light, which is great from a higher perspective of here's a green light medication, this is good for you. But what does that ultimately mean, right? Like, does green light mean that we can give it a normal dose? If it's red lighted, does that mean we shouldn't use it at all, or should it have a lower dose? So how the information is reported, you want to make sure that you're given specific recommendations, not just these lights that you look very patient friendly. Is the evidence for each recommendation available? Again, be really selective with what laboratories you're looking at. Are they taking peer-reviewed considerations and tests into account with their evidence? Are they taking some of these smaller randomized control trial tests? What's the breadth of evidence and how does that relate to CPIC, and what are they pulling into their results? And then another thing to take into account is the lab within a billable network. Most pharmacogenomics labs don't bill, so that's left ultimately up to the provider. I can tell you it is a very cumbersome process. It's normally a prior authorization process, and then you have to bill yourself. And then if the lab's not within a network, it further complicates the picture. But again, these are testing considerations. It's a great test, but it becomes very complicated very fast when we consider scope and reference. And overlaps in other areas of clinical practice. So I'll set the stage again just for the state of Hawaii. A large majority of drug research is done on people that look like me. It is done on Caucasian and European ancestry. According to the NIH, that spans anywhere from 70 to 80% of drug R&D is done on Caucasian populations. And as we know, living in this state, we have a beautifully diverse population where we do not have a dominant race. So 25% of our population is multiracial compared to that of the US. It's less than 3%. There is no majority race in this state. And that is something I think we really need to be taking into account. I feel like the standard of care could look very different in this state, simply based off of the people that we're pulling with R&D to determine guidelines. Asian Americans and Pacific Islanders have significantly different medication processing pathways than Caucasians and are more at risk for medication-related complications. So I know this is a lot on this slide. I just want to point out, specifically looking at some of our minority populations, especially Asian Americans and Pacific Islanders. I mean, look at some of the differences in phenotype here. Increase in Asians having an at-risk phenotype compared to Caucasians. Some of these medications, it's over 600-fold. I mean, over 100-fold. That's why we have to pull some of these medications or some of these genes before we're even allowed to give some of these medications at this point. But again, I've put down in this box going horizontally, looking at different classes related to mental health medications. So looking at our SSRIs and looking at our TCAs, up to just about 6x potential for having an at-risk phenotype. And then the result of that, it's not just give the dose as usual. The result of that is consider a 50% dose reduction in some of these agents, or consider an alternate drug that's not metabolized by these certain pathways. So these aren't just anecdotal increases in risk. These are increases in risk that have a clinically actionable modification that needs to be made to these medications. And something else that I wanted to highlight to bring to everyone's attention, because this was so popular a couple of years back, and this is still so mind-blowing to me that we're not pulling some of these genes prior to to dispensing some of these medications, but specifically with Plavix. So again, remember, Plavix is a prodrug. It's given in its inactive form, and it has to be metabolized to its active form. There is a huge majority of Asian Americans and Pacific Islanders that do not metabolize Plavix to its active form. So here you can see the STAR2 variant, which results in a poor metabolizer. 23 to 45% in East Asians and 40 to 70% in Pacific Islanders. And that has a clinical CPIC level A recommendation of give an alternate agent if possible. And I mean, as clinicians, we know Plavix is given after high-risk procedures. It's to prevent any kind of clotting or stroke that would ultimately end up back in the hospital. Just huge, horrible implications if we're basically giving a tic-tac to a large majority of the population that can't metabolize the drug into its active form. So this will be the last couple slides I have, and then I'll round up for questions. I know I'm barking up right on that 45-minute mark, but phenoconversion. So this is why it is so important. I don't even think I said this at the beginning, so I'll say it again loud and proud now. We cannot just look at pharmacogenomics. This is not meant to be an end-all be-all, just like with any other clinical information. It's not meant to be looked at in a vacuum. There's weaknesses within pharmacogenomics too that make it more complicated and make it very important to have someone who knows what they're doing and knows what they're looking at, rather than just looking at poor metabolizer, here's what I need to do. So another consideration, phenoconversion, the Achilles heel of pharmacogenomics, is not just drug-gene interactions. So what we've been talking about is drug-gene interactions. Now put into the clinical picture, you have patients that are on so many medications. I mean, 40 million patients are on 5 plus medications. This number is going to double by 2040. So now instead of just looking at drug-gene interactions, which is the basis of pharmacogenomics, we're looking at drug-drug-gene interactions. So how are these additional drugs that also affect these pathways now affecting different phenotypes or different metabolic rates? So again, phenoconversion is that mismatch of how we expect them to present, what we expect their phenotype to be, and how they're actually presenting because of another medication that they're on that processes in the same pathway. So I will put this into a clinical context. I've pointed out 2 different drugs, 2 the same drugs that I think will be easy to understand. So looking here, affected drug, we've got Plavix, again, prodrug. Both Plavix and tramadol are actually prodrugs, but 2C19 intermediate metabolizer, just with Plavix, that AUC, just with Plavix being a 2C19 and a patient that's an intermediate metabolizer, they're going to receive a lower AUC of the action of that drug. Now, let's again look at tramadol. It's a prodrug. It goes through this pathway, also anticipated to have a lower AUC of tramadol going through 2C19. When we put those 2 drugs together, because they are competing for the same pathway that is already not working at full speed, we are now going to have an estimated lower AUC of almost double that of just the medications if they were given themselves. So they are going to present as if they are a poor metabolizer or a non-metabolizer because you have 2 medications competing for a similar pathway. So again, let's look at poor metabolizer. We've got the 2 same drugs. Now we're looking at lower concentrations for either of them alone, giving a poor metabolizer status, but in combination, you double that. So now you can see how this just continues to accumulate based off of if you're also on a drug that's going through the same pathway as an effective medication. So barriers to standardization. I mean, if this is such great technology, why are we not using it like in every single patient, every single time we need to prescribe a medication? Again, normally a lack of reimbursement based off the provider. Some providers in the state aren't, or sorry, not the provider, the insurer. Some insurers aren't even covering pharmacogenomics here. But because patients switch insurances so often, it is often harder to get an insurance to bite to cover a broad panel, because by the time a patient would need that panel, if you're proactively pulling it, they may or may not be on their insurance plan. We are already overburdened in the healthcare system. Pharmacists can't bill for services here. So I think that's really what's keeping my profession from being able to step into helping with pharmacogenomics, is because we can't bill for our time. And so it's hard for us to be integrated into a clinic if we can't bill. Technology has outpaced education, and I don't mean for this to be a knock on any provider that's on this call. That is absolutely not my intent, but this is kind of recent to say in medicine, right? Like pharmacogenomic training, many of you didn't get this kind of training in medical school. So now we've got this great great technology and we've got so much that we can do with it, but technology has outpaced a lot of medical providers just based off of timing and education as it stood. Lack of electronic medical record infrastructure. So a lot of these labs don't communicate directly with an EMR. I know none of the systems in the large healthcare systems have electronic conversion with pharmacogenomic results at this point in time. And again, there's no pharmacogenomic labs on island. So now you as a provider, if you wanted to pull a test, would have to know which lab to refer to, how to go through the prior authorization process. It just becomes more cumbersome than simply ordering a test. And last but not least, these are my hot takes. I hope I've really hammered it home that especially in mental health, especially in a state where we're already short providers, we're already struggling with mental health, we already have so many health delays, and because we have so many CPIC level A and B recommendations for mental health drugs and medications, this could be a huge, huge area. And this is one of the biggest implications where pharmacogenomics can have a huge clinical result and not only change the standard of care, but potentially really save lives if we're able to reach a clinical endpoint using genetic data at a faster rate. There's a possibility that the standard of care looks very different in this state than anywhere in the US, just based off of our minority populations and where drug R&D is focused. We need to stop referring to personalized medicine as the future of medicine. This is like one of my personal pet peeves because we're living in the future right now. I mean, we have guidelines that have strong data. The FDA is already putting pharmacogenomic data into package inserts. If that's the case, we're already living in the future. There's certainly a lot to be taken into account with other aspects of personalized medicine, but pharmacogenomics is off to a really great start. Consumers are more educated than before. You can order some of these medications already, or some of these panels through places like 23andMe, or there's other companies where there's direct consumer pharmacogenomic testing. So I have heard of providers that are having to deal with patients that come in and put the genomic results on their desk and not knowing what to do with it. And then pharmacists are playing a key role in pharmacogenomic management. That's just my own personal plug. A lot of randomized control studies and a lot of the biggest pharmacogenomic integration studies into clinical practice are pharmacist driven. And so team-based care, regardless of just looking at pharmacogenomics, I really feel like is the answer to a lot of the problems that we have in the state, is alleviating and really pushing forward with team-based care. So I will end on a quote. If it's not safe, it's not care. This was said by the director of the WHO at their last meeting earlier this year. And I really feel like providing pharmacogenomic testing is one step further in being able to provide safer care. So I have ranted on for 50 minutes. I went very fast. I'm sorry if I was confusing, but I'm happy to take any questions in the remaining 10 minutes that we have.
This is very exciting. When do you think Hawaii will catch up?
That's a loaded question. I do feel like insurance reimbursement will not come until we start asking for it. One of the beautiful things about Hawaii is that we are 1 degree of separation from anyone in this state. There's a lot of key decision makers that are within very close reach. If we can present the data and the need, especially in mental health for pharmacogenomics, we have to be advocates for getting this into our own clinical practice. So start asking for testing. I know one of the insurance companies just started covering single gene testing. So start pushing for that. I mean, really start however we can asking for reimbursement.
And James asks, many prominent psychiatrists lack your enthusiasm for the testing. They're inclined to reserve it for special situations, pointing out that the predictions of efficiency are often wrong and that drugs that do not undergo oxidative metabolism always float to the top of the list of informed recommendations. Tell us about your arguments and why they are wrong.
Sure. I mean, before we even get into the details of different types of metabolism, looking back on those studies and looking at the clinical endpoints, if we don't even want to get that granular, patients are achieving remission faster. They're getting off of medications that have side effects. You know, we're streamlining their therapeutic regimens. So, I mean, we can talk about the different types of metabolism, but ultimately, if you want to really thrump those arguments, look at the clinical endpoints. We're getting to better results and we're getting there faster. And then something else to take into consideration too is don't always look at it just at the specialty level. So when you're just pulling a mental health panel or you're just pulling a cardiology panel, you're still going to be able to change medications outside of your scope. So pulling a genetic test or having this information doesn't only affect your specialty area, but 2C19 with Plavix. Again, if you have that information from a mental health panel, that's great, but now you can unnecessarily avoid giving a patient Plavix where it's not going to work. It's not just looking at it at the specialty area, but the clinical picture of the patient as a whole.
And Sherry asks if people can pay privately and how much it costs. I know you said before $250 for a mental health panel.
No, you can do $250 for a comprehensive test.
For everything that's available now to test against.
For everything that's available now to test. Yes.
Okay.
Yep.
And then you can just keep it and you can
I'm
tell your
sorry,
doctor.
how much
well,
does that test cost? 254?
250 for a broad panel. So anywhere from 30 to 60 genes. And that is really different. If you look up ARUP right now, which is what most clinicians are using, I know they're charging $300 and something for one gene. So you can do 250 for a broad panel. It's totally possible.
And so you can just keep that. And then when your doctor says, I want to put you on this, you can say, oh, it looks like I don't actually break that down very well. How about?
Exactly.
And Renata asks
Exactly.
how long the results are valid. Wouldn't that be forever with those genes?
Forever. You know what, Renata, great question. I don't think I said that. Your genes don't change for the duration of your life, right? So yes, some drugs do modify certain certain genes, and I think I kind of denoted the specifics of those. These pathways in the liver, your CYP pathways, your cytochrome pathways, are not going to change. So these results are valid forever. What I will say is that the data is only going to grow. So someone who gets a pharmacogenomic panel now, who's to say we don't have 100 additional medications in 5 years that now have CPIC level A or B guidance? So it's being able to translate the genetic results that you're given at this certain point in time, and then translating those to what can also apply in the future.
Oh, this is really fun. Where can I go to have that panel done? Kristen says.
I don't know if I'm allowed to say this, but I can help you. I can help you with that. Yeah, and that's what, yeah, that's I'll put my email in here too. Oh, it's on the slide right now. That's on the screen, but
there you go.
Yeah.
So most labs will have some studies they can do, right?
Mm-hmm.
But you would want to call your local lab and say, what genetic testing can you do for medication sensitivity? Right?
You know,
I mean,
I don't even know if medication sensitivity would be the right word, because I worry if they would, I feel like that might be a bigger ask.
so what would you say? So if you called DLS, and what would you say to see if they could do?
Say I'm looking to have pharmacogenomic testing done. Which genes do you test?
Okay.
And there's a repository on each of the lab's websites. Well, they'll be able to show you which genes and which alleles they test.
Got it. And then you could ask them how much that would cost. And
Yep.
So you could do DLS, you could do clinical labs, you could ask Kaiser, you could go to Huna Health, you could, that's the
Mhm.
questions you would ask. Excellent.
Mhm.
All
Yep.
right.
Yeah, I know that some provider, well, actually, I don't know how detailed I'm allowed to talk without being
We'll just
conflict
leave
of
it at
interest with
that.
the CE. Okay.
You can call your
call your insurer.
Yeah, call your insurer, see what's covered, call your local lab, see what they can do. Yeah, and there's her number. Let's see. And then next week we have David Sprouse. It's our last of our 5 CSAC ethics sessions. So he's covering ethics number 9 and 10. Ooh, are there 12?
There's 12.
Ethics? Oh my gosh. Okay, so it's not the last. Either that or I can't count, one or the other. I don't know. But okay. Well, this was really informative. And let's see, great presentation, lots of mahalos there. And there is her email if you guys want to ask any additional questions. So thank you so much.
Thanks for having me, guys. Remember, I don't think we'll get coverage until we start asking for testing. So it's up to this group to start pushing for it. It's got to come from the bottom up.
Right. It's interesting. And not all medications are identified with certain genes, right? I mean, we have more medications out there than we have knowledge of how they're broken down necessarily. So probably what's going to expand in the future is that knowledge. So, your first testing might not cover new things that, well, of course, new things will be developed and then we'll have to test for those too. But it is very interesting as far as individual health needs. Right.
Well, great.
Well,
Thank you guys for having me. Thanks for such an engaged chat. I love it when I feel like I can give real life feedback that works. So thanks for being engaged and thanks for having me, Kelly.
Thank you. And Ella says many take what the doctor orders regardless of whether it really works or not. But hopefully you'll go back to your doctor and tell them if it works or not. And then if it doesn't work, there's things to do to help test why not. So, all right. Have a great week, everybody. See you next week.
Bye, everyone.
Hello, everyone.
Thanks, Corrie.
Bye.